Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as the program facilitator and will present your questions to our panel of physicians. This evening, specialists from endocrinology, urology, and urologic oncology will discuss various men's health topics and the importance of putting your own health at the top of your to-do list. Remember, the steps you take today are your first steps to a healthier tomorrow. Well, thank you so much for submitting your questions in advance. And the questions you will hear me asking the physicians tonight are all submitted right from when you registered for this webinar. So if you have any other questions throughout the discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A, and you can go ahead and type your question in the text box. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate that annoying background noise, so feel free to move around and get comfortable. So with that, I want to go ahead and introduce our experts for the evening, starting with Eric Schifrin, MD, endocrinology, and Perry Weiner, DO, urology and urologic oncology. Well, thank you both so much for joining us this evening. I know we're going to have a very interesting discussion based on the questions we've already received. So let's get to it. So question number one, I'll start with you, Dr. Weiner. When should men start getting checked for prostate cancer? And if you want to go ahead and unmute yourself, sometimes.
There we go.
Perfect.
Technology. Great. Thanks. I appreciate the invitation and hope to answer the questions this evening. So this is an excellent question. Typically, what we recommend is that if there's no family history of prostate cancer, we recommend that men get PSA testing and a physical examination, which is a rectal digital examination of the prostate annually. If you have a family history of prostate cancer, or if you're African American, we recommend that be pushed back to the age of 45. If you have a family history of prostate cancer and you're African American, we would recommend that the evaluation begins at the age of 40, and this should be done annually.
Okay. Great. Thank you so much. Dr. Schifrin, we'll go to you along the same lines. Why would men need to see an endocrinologist, and when should they start seeing one?
Thanks, Sarah. So I'm happy to be here. Should be a great night. I'm looking forward to a really good discussion. So yeah, endocrinology. I guess sometimes not everyone knows what endocrinologists do, but we see patients for any hormone issue. Very common reasons that a man might need to see an endocrinologist. Number one would be diabetes. That is probably the most common patient we see in any endocrinologist across the country, just with the prevalence of prediabetes and diabetes. So along those lines, if you have uncontrolled diabetes and it's been going on, you're following maybe with your primary doctor, but it's been uncontrolled for we'll say over a year, definitely think about getting a referral to an endocrinologist, especially if you're someone that's been on insulin or more medications are being added. Other common reasons along the lines of men's health would be any testosterone issues. So men with a pathologic reason to have low testosterone, and that's been documented, should seek out care of urology and or endocrinology, who both work together to treat that issue. Endocrine's also very broad, so we also see other things such as thyroid disorders, adrenal disorders, pituitary disorders, as well as osteoporosis. So there's a number of reasons, but the most common reasons would be diabetes, testosterone issues, and thyroid issues are probably the top three for men.
Okay, great. Thank you so much for walking us through that. All right, let's turn back to you, Dr. Weiner. We'll talk a little bit about screening. So what screenings are essential for men to get?
From a urologic perspective, as we talked about, PSA testing for all men starting in their teenage years and going through lifetime, I encourage patients to do testicular self-examination. This can be done. In the shower once a month. Every man should become familiar with what his anatomy feels like, so that if there's an abnormality which is felt, or there's something which doesn't feel the same on one side than the other, then that's a reason to go visit your urologist, where an examination would be done by us, and perhaps we might even order an ultrasound, because the incidence of testicular cancer is, although not a daily thing that we see, it is not an uncommon thing. So prostate examination, testicular examination. Similarly, although it's extremely uncommon, men do get breast cancer. There are about 1,000 cases or so a year that are diagnosed annually in men. And unfortunately, because breast cancer in men does not get the same play in the media that it does for women, men tend to think that that's a woman's cancer, but in fact it's not true. So you should also have you should also become comfortable with examining your breasts. Sadly, because men are relatively uninformed about the prevalence of breast cancer, when it's diagnosed in men, it's often much later and much more difficult to manage and control. So testicular cancer, prostate cancer, breast cancer. We should also be visiting with our primary care physicians to ensure that we have scheduled colonoscopy on a regular basis. And I think that screening, I'm not exactly sure when that occurred. Perhaps Dr. Schifrin, who's an internist by trade as well, would know the timing when a current colonoscopy should be started. But certainly if there's a family history of colon cancer, then perhaps colonoscopy may be considered when a patient is young as in their mid-30s. But then again, although nobody likes to prep, which is the most uncomfortable part, my understanding, Eric, correct me if I'm wrong, if a patient has an unremarkable colonoscopy, perhaps that test isn't recommended for another 10 years.
Yes. So some of the newer guidelines, general screening starts at age 45. It used to be 50 or 10 if you have a first degree relative, usually 10 years before, whichever comes first.
Now, just to clarify something for the audience, if you can, my understanding from my reading is that a lot of people are using the Cologuard test. And although Cologuard is marketed as being able to detect colon cancer, and it can, maybe some people might think it's a substitute for colonoscopy. My understanding from talking to my GI colleagues is that Cologuard can detect abnormal DNA cells for patients who already have colon cancer, but the idea is to find somebody who has a polyp or a precancerous condition before it becomes cancerous. So don't let Cologuard substitute for colonoscopy. Do you think that that's an accurate statement?
Yeah, totally agree. And it's not for high risk people, and so it's not a substitute. So it's not a test that I order. I depend on my primary care doctors, but certainly follow your primary care doctor's advice or your gastroenterologist. But what you said, I agree with.
All right. Terrific. Some really important information there. And just so the audience knows, you will be getting a recording of this. So no need to take meticulous notes because there was some great information. Thank you for walking us through that, both of you. Okay, so let's turn to Dr. Schifrin. Just talking about the hesitancy. So for someone who maybe has hesitated getting screened and tested, or even seeking treatment in general, what questions should they be asking as they turn 50?
Age 50, nothing magic happens at age 50, but I think it is a point where people start thinking about their health in general. Certainly, by age 50, everyone should have been screened for diabetes. And in fact, the guidelines say that diabetes screening should start at age 35, or at any age if your BMI, body mass index, is even just above 25. And so that's a lot of people. Asian Americans, it's actually 23, especially if you have an additional risk factor, which could be a first-degree family member with diabetes, high blood pressure, high cholesterol, a sedentary lifestyle. And so for the most part, if you're age 50, screening for diabetes. And most of the time, if you've had routine labs, your doctor has seen at least a blood sugar, but they'll often also get a hemoglobin A1C, which is basically a blood test that tells us what your 3-month blood sugar average is. So that's one point. Dr. Weiner mentioned by age 50, everyone should be getting screened for colon cancer, number 2. And then I would say number 3, if you're someone that does have a sedentary lifestyle, really take a look at your diet. It's a time where if you are someone that's maybe eating out a lot, eating a lot of processed food, and knows that you're someone that can have an improved diet, something to talk to your doctor about. There's good resources. We have really fine registered dietitians here that help our patients. We have a weight management program here at Jefferson, and so that would be one other aspect of health that I would take a look at as you approaching 50 or hit that 50 mark.
Okay, thank you. And Dr. Weiner, any other thoughts you would like to add there? I know.
Actually, there was something that crossed my mind. We were talking about it, and I don't mean to ignore my dermatologic colleagues. We spend a tremendous amount of time in the sun, particularly if we go down the shore, we're outdoor sportsmen, fishermen, golfers, people who just like to talk walks. But it's also very important to be screened for skin cancer. And that's something which people should make appointments to see their dermatologist for, or perhaps their primary care physician can do this. But dermatology certainly is expert in finding these early cancerous lesions. There are different types of skin conditions, some of which can be actually quite dangerous. So not all skin cancers are very dangerous. There's a small number of patients who develop, unfortunately, a melanoma, and that can be a small brownish or blackish discoloration of the skin. We might think it's a mole, perhaps if it has an irregular border or it starts to change over a period of time, or you're just not real comfortable with how something looks, or if something appears new, then that is something which should be investigated immediately. So that's something I feel strongly about sending patients for. Having had personal experience with this, I can tell you that it's a crucial evaluation.
Well, thank you for sharing that, especially knowing that you had a personal experience with this. So really important information for people to hear. I guess as a follow-up and more general question too, do you have any big questions that you think are important for patients to be asking if they're seeking care?
Well, I think it relates mostly to what we've said already about the screening that we should do. Is there particular blood work we should do? I think that patients should be aware of the issues that relate to tobacco use and alcohol. So everybody knows about tobacco use, and the Surgeon General's, had these little warnings on the side of cigarettes since the early 1960s, and everybody's concerned about the risk of lung cancer with tobacco, and that's well documented. But there are other aspects of tobacco use that perhaps we're not aware of in the general community. For example, It's the number one cause of oral cancer, throat cancer, tongue cancer, laryngeal cancer. It's the leading cause of esophageal cancer. It's also the number one cause in the United States of bladder cancer, which is something that I take care of very frequently. So patients may experience frequency of urination, urgency, perhaps even the smallest trace of blood. If you were to see blood in the urine, that is a mandatory urologic evaluation, in our opinion. So I don't want to diminish the importance of discontinuing tobacco use as soon as possible. Similarly, alcohol use is controversial. You know, there are a lot of people who say, oh, it's good to have a glass of wine or two a day. I'm not a cardiologist, and I don't necessarily have the expertise to speak to that, but certainly anything that's done to excess is detrimental, and excessive alcohol use is also directly related to esophageal cancer, liver disease, and other dangerous conditions.
Okay, thank you so much. Again, terrific information being shared tonight. As we know, this often patients will go first to their primary care physician. So Dr. Schifrin, I do want to ask you if you have any suggestions for patients when they're picking a primary care doctor.
Sure. So I get asked this question a lot. A lot of my patients need a primary care doctor, or they just moved to the area, or want to switch for location reasons, various reasons. So the first thing I would say is, ask for a recommendation from a provider that you're comfortable with and that ask for recommendations from friends, colleagues, neighbors, as well. That's always important to find someone you're comfortable with. And I would say, not everyone, if you meet someone and you don't feel like they're for you, most people don't get offended. You're free to, find who might work well for you and your personality. I think a primary doctor is someone that communication is key. So it's someone that you can easily communicate with, easily get a hold of in a reasonable time frame, and someone that communicates well to their colleagues. So I always appreciate when a primary care doctor or any of my other colleagues keeps me in the loop and communicates well with me. So that's one thing, one real important thing that I would stress. And just comfortable talking with them, seeing them in the office is the most important thing, because it should be someone that you create a long-term relationship with.
Absolutely. Sounds like it's important to listen and trust your gut when having these conversations. So thank you. Okay, we will turn to our next question, but just a reminder for the audience, feel free to submit any questions you have stemming from this conversation, and we will get to all of our live questions at the very end. So again, feel free to submit those as we are discussing tonight. Okay, next question for both of you, but I'll start with you, Dr. Weiner. What would you say the top men's health issues are, and what preventative measures can men take to avoid them?
So the two most common things that I see concentrating my practice on men's health are difficulty with urination, prostatic enlargement, and erectile dysfunction, inability to achieve a strong erection. As far as prostate enlargement, sadly, there's nothing we can do to prevent it. It's a part of the aging process, and I'm not sure that there's any studies that show that zinc, pumpkin seeds, any zinc vitamins, multivitamin supplements, things like that, are necessarily preventive in terms of urination issues. And certainly if you have difficulty, if a patient has difficulty with urination, getting up at night a lot, incomplete emptying, slow stream, urgency to go to the bathroom, again, as I said, bleeding, that's something that should be evaluated. This doesn't always necessarily mandate surgery. In fact, in today's day and age, many of the patients that we take care of are managed with medications. As far as the erections go, or don't go, the most common reason we see patients for includes diabetes, heart disease, high cholesterol, triglycerides, and tobacco use. So we do know there are some very elegant studies that have been well publicized and validated in the medical literature that the onset of difficulty achieving a strong erection is a very, very strong indicator of future heart disease, particularly in patients who smoke. And that's because the blood vessels that allow us to have an erection are quite small, particularly compared to the blood vessels that supply our heart and our head. So those vessels that are small are going to become clogged or occluded first, perhaps because of tobacco use, atherosclerosis, triglycerides, things that clog arteries. And that happens many, many years in advance of a patient having, let's say, symptoms of heart disease or a stroke. So those are the two most common things we see.
Okay. And really interesting to hear those indicators and obviously just the importance of then seeking care. So thank you. Okay. And Dr. Schifrin, any thoughts there or additional things you'd like to add?
So no, I mean, I agree with Dr. Wiener. The original, just remind me the original question that you wanted us to address.
Just any top men's health issues that you think are most prevalent right now that you're seeing in your practice?
Yeah, certainly. So yeah, I would say concern for low testosterone, libido issues. Some men do have low testosterone when they come to see me. Sometimes it's more of a there's other secondary factors contributing to how they're feeling, such as low libido, erectile dysfunction, fatigue is a common one. And it's not that sometimes it is a testosterone issue, but I think often some other factors get missed. So one that comes to mind, a really top issue, which I don't think we mentioned, would be sleep apnea. A lot of men have undiagnosed sleep apnea, very, very common, and it is associated with low testosterone. Treating sleep apnea has been shown to raise testosterone in men that have mildly low or low testosterone, and addressing other factors such as diabetes, diet, sleep. All these things are something that I talk to my men that have maybe mildly low testosterone, may not need testosterone therapy, but may just need other lifestyle issues. That's one other thing that came to mind. And then the second always comes back to diabetes, blood sugar management. Extremely important because of all the multi-organ dysfunction that uncontrolled diabetes can cause. Leading cause of death for diabetes would be cardiovascular disease.
Okay, thank you so much. All right, let's go to our next question and another for both of you. We're going to talk a little bit about the trends here. So any new trends or upticks in men's health issues since the pandemic began? I'll turn it to you, Dr. Wiener, to kick us off with this one.
Right. So unfortunately, the pandemic limited the access of many patients to the medical system, so that there was a delay in diagnosing many different issues, which could be serious. So I would strongly encourage all men and all family members actually to get back on track, because I think the risk of ignoring things, in my own personal opinion, balanced against the risk of a COVID exposure, I think the risk is such that it doesn't pay to delay routine medical care. In terms of sexual function, I guess the latest thing that we're talking about for erections is the use of wave therapy, sound wave therapy, which has been shown to stimulate blood vessel development to improve erections. And it's a non-invasive test, which we're offering here at Jefferson through the Men's Health Program within the Department of Urology. And that is a very good way for men to supplement their erectile ability without the use of medication and certainly without the use of surgery. So that's probably the most important thing from an erection perspective. In terms of prostate disease, medications pretty much haven't changed, but there are a variety of new surgical techniques that we're employing for patients who are either not candidates for medical therapy or who have failed medical therapy. And that includes the use of lasers and water therapies, which can eradicate prostate tissue, as well as a suturing device, which is done as an outpatient, where we place a couple of stitches into the prostate to tether it open to improve urinary flow. Those are the latest things that are very well received and have excellent patient response.
Wow, and exciting news to hear. So thanks for taking us through that. And interesting, anything interesting to Dr. Schifrin that you'd like to add that you're seeing?
Yeah, I mean, it has been publicized that, there seems to be an uptick in diabetes after the pandemic. There's probably a combination of reasons for that. But I think it is probably more than just kind of delay of care, people that hadn't seen their providers. There seems to be something with high risk men or women, for that matter, that got COVID, that seems to put them at a bit higher risk for developing diabetes. It's unlikely that someone that had completely normal blood sugars after gets diabetes. It's probably more the person that maybe had borderline diabetes, but it could have kind of tipped them over to full-blown diabetes or uncontrolled diabetes. So just something that to keep in mind if you are someone that maybe hasn't, got routine labs or seen their provider, especially if you had COVID, to just get that checked. And I just want to add that I didn't talk about it, but keep in mind symptoms of uncontrolled blood sugars. So increased urination, increased thirst, very high sugars can start to cause weight loss, unexplained weight loss. And so if you're experiencing any of these, definitely get yourself checked.
Okay, thank you for that reminder there. All right, so we will continue talking about kind of the latest trends here. Dr. Wiener, let's talk a little bit about aquablation. Can you tell us a little bit more about aquablation and how does one know if it's right for them?
So there's no one surgical option which is best for every single patient. Aquablation is it's a robotically controlled handpiece done under direct vision, which uses high pressure water under ultrasound control to trim out prostate tissue. It's relatively new in the marketplace. It is established as an alternative for some patients whose prostates are of a certain size. Currently, the recommendations from the American Urologic Association endorse the use of this treatment for prostates that are between 30 and 80 grams in size, although there are many reports in the literature that have shown very good success with this treatment for patients who have prostates that are much larger. Again, as with any surgical treatment, every surgical treatment has its pluses and minuses, and there are many ways to handle enlarged prostate, aquablation being one of them. As I said, it's a relatively new procedure. We don't have the long-term experience with it that we do with some other traditional procedures. It still requires the patient to have endoscopy or a cystoscope at the termination to make sure that all the bleeding is controlled. Patients still require a catheter after the procedure, and often the patients still require a hospital stay overnight. So again, it's a new technology that's out there, very exciting, but not always for everybody.
Okay, got it. So important to weigh your options there. So thank you for taking us through that. Dr. Schifrin, in talking about a little bit about diabetes here, is metformin still a good diabetic medication? And if not, what are some other treatments available?
Yeah, so this has been coming up more. I think there might come from some news articles from various sources, but the short answer is yes, it is very safe, effective medication. It's still considered the first line treatment by the American Diabetes Association for diabetes, and that is supported by endocrinologists. Most endocrinologists are still using it for most people. A lot of people have some trouble tolerating it due to GI side effects, and so some people aren't on it for that reason. Some misconceptions that I hear about metformin could be damage to the kidneys, which is not the case. The dose does need to be adjusted if you do have kidney dysfunction, but the metformin itself doesn't cause kidney dysfunction. High blood sugars and uncontrolled diabetes is what damages the kidneys. So if you're on it, it's a good medication. I would not stop it if it's working. If you're having side effects, talk to your provider about that. There are other options. There's plenty of other good options that we often use in place, or most often in addition to metformin. The GLP-1 agonists, most of which are once a week injections. Some of them are Trulicity, Ozempic. They are once a week injectables that are very good at controlling sugar. They're the best medications for weight loss and controlling diabetes. And then there are other tablets that have been shown to be beneficial for the kidneys, the SGLT2 inhibitors, Jardiance, Farxiga, Invokana. These are medications also being used more and more. The other exciting thing about those two classes of medication is that for the first time, we've shown cardiovascular benefit, which 20 years ago there was no medication that could show that you can prevent heart attacks and strokes. And so for the first time, a lot of these medications, many of them have been shown to be not just safe cardiovascular, but beneficial. Reduced chance of non-fatal heart attacks, non-fatal strokes, and also can in terms of the SGLT2 inhibitors, decrease progression of chronic kidney disease.
Wow. Really exciting to hear that. So thank you for sharing. And good to hear, that there's other options available if needed. Okay, so we have one last question that was submitted earlier from when you registered, and then we will turn to our live questions because you've certainly been submitting them in the chat, so we appreciate that. All right, Dr. Weiner, one last question for you before we dive into our live Q&A. No, you mentioned this earlier in our discussion, but talking, yep, a little bit.
Sorry, I said yes.
Okay, perfect. Thank you. Do you mind talking a little bit more just about wave therapy for ED? Maybe just kind of talking about the pros and cons for people if they're considering this?
Yeah, so let's start with the cons first because they're very few. It can be associated with a little bit of bruising. It can be associated with a little bit of very minimal discomfort. It is not covered by insurance because insurance companies haven't signed on yet as to the entire benefit for it. But there is excellent science behind it. So these are the pros. There have been multiple studies that have shown that the use of sound waves, which pass harmlessly through the tissue, cause the release of certain tissue factors which stimulate blood flow. It creates a small amount of inflammation, which is shown to be helpful for the development of blood vessels because the small amount of inflammation that occurs actually releases certain tissue regenerative factors, things like VEGF and cytokines and other tissue chemicals, which are very important for tissue healing. And because of that, new blood vessels can grow in. And of course, the ability to achieve an erection depends on blood vessels. But the other aspect of it is that there's a neurologic benefit in that it seems to have some benefit in terms of the nerve signaling that go to the blood vessels that allow the blood vessels to open and close, which is all done under neural and nerve control. And there's some very good science which has shown that the use of these sound wave therapy is stimulating to nerve tissue, which improves erections as well. Treatments are generally done in groups of 6. They take about 20 to 30 minutes. Patients can come in once a week to the office. It's a small little microphone is applied, and it's applied to different areas to improve blood flow. There's also a disease called Peyronie's disease. Peyronie's disease is a bending of the penis, whereas when a patient achieves an erection, it's not straight, but it's bent. And that bending can be minor or it can be severe. It can be even up to 90 degrees, like a right angle. And certainly that impedes sexual performance, and it's also very uncomfortable. And there's a lot of good science out there that the abnormal tissue that causes that may be disrupted and healed with the use of sound wave therapy. So there are a couple of applications we're using it for with some very promising results.
Certainly some promising results. And it sounds like you listed a lot more pros and cons. So maybe something to consider for people listening. Okay, well, thank you so much. We are going to dive into our live questions right now. And we've been receiving a few in the chat. So excited to continue this conversation. Dr. Schifrin, we'll start with you. Question from the audience. Would you screen for secondary causes of diabetes if a 40-year-old man with normal BMI without family history is recently diagnosed with diabetes? If so, what would you be looking for?
Yeah, so great question. When I see a patient middle age, normal BMI, no family history of diabetes, the thing that I would want to know, so I would check some other things and not just assume that it's type 2 diabetes, which is just caused by insulin resistance. There are people with normal BMIs that get type 2 diabetes, but I would want to look for what's called autoimmune diabetes, LADA, some people call it. Essentially what that is it's type 1 diabetes that could present in middle age. So it's an autoimmune phenomenon where antibodies destroy the beta cells, the insulin producing cells of the pancreas. So there are antibodies that can be checked. There are GAD65 antibodies, and there's one called zinc cotransporter 8. These are antibodies that I would screen because it does affect management. If someone has autoimmune diabetes, essentially type 1 diabetes, or is progressing towards that, really insulin is going to be key. Whereas if it's type 2 diabetes, then you can utilize a lot of these non-insulin medications, some of them which I just mentioned before. So that would be one thing to look at in that case. And is not always a family history of this. It can come sporadically. We don't quite know why, but it's something that should be checked, in my opinion.
Okay, great. Thank you so much. Dr. Weiner, we'll turn it to you with another question. I'm a type 2 diabetic as well as stage 4 NASH. I have a protein leak and was taken off metformin, placed on Varziga, and now have muscle mass loss in right arm. Are there any updates, treatments, etc. for protein leaks?
So I'm not terribly familiar with protein leak as it relates to the medical problems that you're talking about. So again, as you mentioned, Sarah, we're not really diagnosing and offering advice, I should say, to individuals during this webinar. I would say that in general, when people have muscle weakness, particularly with symptoms like that, baseline studies that Dr. Schifrin had referred to earlier would be important, including measuring testosterone levels.
Okay, great. Thank you. I have another question for you. This one a little bit more general. talking about overactive bladder. So what is the recommended treatment for overactive bladder syndrome? I currently awake 2 times per night to urinate and sometimes have urgency. And this is from one of the audience members.
So thank you. That's typically related in men to enlarged prostate, although there are many things which can cause overactive bladder, also known as I gotta go, I gotta go. So there's a difference between patients who only get up, in my mind, there's a difference between patients who only get up at night or patients who have the problem around the clock. Patients who get up at night, this is known as nocturia. That can be due to multiple factors, including diet, including medications, salt intake, whether or not they have adequate circulation in their legs. All of this contributes to nocturia, as well as Dr. Schifrin's comment earlier about sleep apnea and diabetic management. And also, as we get older, our ability to generate a hormone called antidiuretic hormone, or ADH, that hormone's level naturally decreases as we get older, and that can contribute to our urge to get up in the middle of the night. But if a patient has overactive bladder urgency frequency, which occurs daytime and nighttime, the things that I would check for: number one, is the patient diabetic? So, do they have an underlying neurologic disease? Because the bladder is controlled by nerves. We also check for prostate enlargement and to make sure the patient's emptying the bladder well. Of course, we have to make sure that there's no infection present, because infection can give you the symptoms as well. So there are a lot of reasons why patients can develop overactive bladder. The medications that are out today are very effective in controlling it, but they don't necessarily always address the root cause. And I try to find a root cause and address that rather than just manage a symptom.
Okay. Thank you so much. Dr. Schifrin, we'll turn it back to you. What are there indications for recommending hormone replacement therapy for aging men, and when is it recommended? Specifically, how can I tell if I have low testosterone compared to age-related issues?
Yeah, so a very good question. And as of now, the Endocrine Society does not routinely recommend testosterone replacement if it's determined that it's a normal decline in testosterone with age. It's every man's testosterone generally declines as they get older, completely normal. It's not mildly low testosterone is not dangerous for your health. What I would do is just I try to evaluate, is the testosterone level appropriate for that patient's age? It can be difficult. I mean, testosterone, the reference range for testosterone when you get it at a lab is wide. It's something like 300 to 1100. And as of now, they don't break it down by age. The provider really has to do that. And so in general, total testosterones under 300 are considered low. But other considerations, it's a little more complicated than that. There's something called a free testosterone level as well, which often needs to be checked because certain conditions like obesity, diabetes can make total testosterone low when your free testosterone can be normal. So I think I think the take home is don't be concerned by normal declining testosterone with age. Don't start testosterone on your own without the advice of your provider. Testosterone is a controlled substance. It does have side effects, and you only want to take it if you need it. And no studies have in routine replacement in older men have shown clear benefit. For men with undisputed low testosterone, yes, there are studies that show some improvement in cardiovascular factors, quality of life, but only for men with truly low testosterone.
Okay. Thank you so much for walking us through that. Another follow-up question for you on a separate note. Can you review how sleep apnea impacts testosterone levels? Know that you chatted about this earlier in our discussion. And this person is wondering, would that still happen if sleep apnea is relatively well controlled?
The mechanism is not well understood. It's there's just theoretical, but so we don't quite know why, but it probably has something to do with sleep quality, circadian rhythm. Sleep deprivation has been shown to lead to everything from high blood pressure, low testosterone, increased cardiovascular risk, especially when sleep apnea is involved in the sleep deprivation, because there's a pathologic reason. There's lack of oxygen flow multiple times a night to the brain. And as far as the second part of that question, no, I mean, if sleep apnea is well treated, it should really not contribute any longer to low testosterone. And I'm always, the guidelines for testosterone therapy recommend not starting testosterone therapy in anyone with severe and untreated sleep apnea, because it can worsen sleep apnea as well. So, but if you're using a CPAP machine, well controlled, then it's no longer really a concern.
Okay, thank you. All right, now a question for either one of you. So whoever wants to chime in, feel free. Years ago, my physician told me not to eat after 8 p.m. Sometimes my schedule doesn't allow for that, and I eat later. How long would you recommend I allow my body to digest before going to bed? And whoever wants to,
I can jump in. So, yeah, I mean, there is some evidence that eating late, eating too close to bedtime, does contribute to increased weight, increased obesity. Especially, I see it in patients that have diabetes. You're eating late, especially a high carb meal. It's very hard for your body to digest when you're sleeping. So I see patients on continuous glucose monitors. Their blood sugars just kind of stay high all night and really have a really hard time coming down to normal. So yeah, I do instruct my patients to try to not snack after dinner, have a cutoff time, maybe 7-8 p.m. And that's for not just for blood sugar control, but just for calorie control. You tend to slowly gain weight that way, and people tend to do better metabolically if they have maybe a period of 12 hours where they're just not eating anything.
thank you. We'll keep that 12-hour period in mind. So good to know. Okay, Dr. Weiner, question for you. What are your opinions on low-dose tadalafil, and sorry if I mispronounced that, for prostate enlargement, and is it still recommended?
So tadalafil, which is the generic name for Cialis, Cialis comes three ways. It was originally marketed for sexual dysfunction at the 10 and 20 milligram level, but 5 milligram tadalafil has been shown to cause smooth muscle relaxation. And it works through pretty much the same mechanism as the drug that we commonly know as Flomax. So these drugs do not control prostate size. They do not control prostate enlargement. What they do is they relax the muscle at the neck of the bladder and a portion of the prostate to allow urination to occur with a greater flow, greater stream, better emptying. And it can reduce some, and I don't want to say anecdotally, but as a secondary effect, can reduce some of those symptoms of urgency in getting up to go to the bathroom at night. But the drugs like Flomax and tadalafil are not intended to control prostate growth. And in fact, over a period of time, the prostate continues to grow, and these drugs typically fail after a period of time because, again, circling back to my comment before, these drugs manage symptoms. They don't really go to the root cause of the problem.
Okay, thank you. All right, Dr. Schifrin, question for you. Is low-dose metformin used for prevention? Does it contribute to any general health benefits?
So I assume the question means with patients without diabetes. So yeah, so no studies have definitively shown that metformin should be used routinely in someone without diabetes. And even in the patients with pre-diabetes, so that would be an A1C between 5.7 and 6.4. The large study comparing metformin to just lifestyle modification showed that intense lifestyle modification reduced the risk of diabetes more than metformin. So number one, you don't need metformin to necessarily prevent diabetes. That being said, that was a study. In real life, if I see someone that for various reasons, arthritis, or someone that really is not going to be able to really do rigorous exercise or really can't change their diet, I do consider it in that pre-diabetic person. The question also might be hinting at, there are some studies that maybe suspect that it might have anti-cancer benefits. And a lot of it is, there's been maybe some studies that show some benefit, especially in animal models, but as of right now, there's no FDA recommendations to use it routinely outside of diabetes. There are some other indications, like this is a men's health talk, but PCOS in women. But as far as no diabetes or pre-diabetes or cancer prevention, nothing recommended right now.
Okay. Thank you so much. Another question for you, so you're not off the hook yet.
Sure.
Can you share your thoughts on the reported possible increased risk of insulin resistance, pre-diabetes, diabetes among those treated with statins like rosuvastatin?
Yeah, so rosuvastatin, all the statins are generic. So generic of Crestor. So common ones are rosuvastatin, atorvastatin, simvastatin. Yeah, so this comes up. There is truth to statins causing some degree of insulin resistance and mild hyperglycemia. The degree that it does is so insignificant that it's not worrisome, and the benefits that statins give for anyone with diabetes far outweighs any risk. So the benefit you're getting by preventing cardiovascular prevention you're getting totally outweighs any increase in blood sugar that you should take it. It's not a reason not to start it or not to be on it for most people, and that's general. Of course, there are reasons why someone maybe shouldn't be on it, but that would be between you and your provider.
Okay, thank you. Now a question for either one of you. Could you please comment on inflammation diets related to aggravating insulin resistance and hence diabetes? So if either one of you has any thoughts on inflammation diets.
So I can comment a little bit. I mean, as far as diets and diabetes, the only diet that's been shown to in a randomized controlled trial to have benefit for diabetes is really the Mediterranean diet. I know there are anti-inflammatory diets out there for people with concurrent inflammatory diseases such as rheumatoid arthritis. Some people with Hashimoto's thyroiditis or thyroid issues try to follow that. It's not guideline based, so I don't recommend. I can't recommend anything other than Mediterranean diet. Anything else is sort of on a patient by patient basis, as much as I can say.
Okay, thank you. But we'll keep in mind Mediterranean diet. Good to know. All right, Dr. Weiner, question for you. Can you elaborate on the UroLift procedure? What is the success rate? What are the benefits compared to other procedures and medication?
So great question. UroLift is heavily advertised. It's one of the newer treatments that I was alluding to before when we talked about prostate disease. UroLift essentially is an outpatient procedure. It's done fairly simply, where a scope is placed inside and there's a device which delivers stitches into the prostate to kind of tether or tent the prostate open. There's no cutting of tissue. The benefit of that is, first of all, it is done as an outpatient. It's good for patients who have moderate symptoms and perhaps can't tolerate medication, don't want to take medication. Perhaps they're not compliant with medication because they're taking so many already, or the cost of medication. And let's not overlook the cost of things these days. So UroLift is a good alternative for those patients, but UroLift should have strict criteria. Again, it should be limited by prostate size. It also needs to be limited by prostate anatomy. And without delving into the weeds too deeply, the prostate has lobes, lateral lobes, kind of like, well, how can I describe it? Let's say when we urinate, imagine taking a drinking straw and sticking it through an orange. So as the fruit enlarges, it begins to pinch the drinking straw, and that's the urethra. So UroLift is good for that. But there are also some patients who develop what's called a ball valve obstruction or a middle lobe, and that kind of is a lump of prostate tissue that sits at the opening to the bladder. When we use UroLift, we're stitching the prostate tissue to its capsule or to the outside. But if you have a middle lobe, there's really nothing to adequately stitch it to, in my opinion. So the problem is that UroLift isn't good for those patients. The point I'm getting to is that every treatment has to be individualized to every patient, and UroLift is not intended for every single patient. It's good to alleviate symptoms. Patients do experience an improvement in urinary flow, but the literature also shows that if you were to actually measure the improvement in how much you urinate in a given period of time, there's not really a great study that shows that the urinary flow is dramatically improved from a scientific perspective.
Okay, got it. So again, just important to weigh your options there, but thanks for taking us through that. All right, I know that we're coming up at the end of the hour, so we'll just take 1 to 2 more questions and then wrap it up. But Dr. Schifrin will have a question for you. Should patients with type 1 diabetes be screened for pancreatic cancer per ads regularly on TV?
Mm-hmm. Yep. So it's not routine. You need to take into account, again, the individualized factor. Certainly, if there's a family history, there are guidelines for patients with first-degree family members with pancreatic cancer, even outside of diabetes. It's not routine. We don't routinely get imaging for patients with type 1 diabetes. There is some truth that there, in certain situations, there is an increased risk of pancreatic cancer with diabetes, and there's a lot of factors to that. A lot of times, patients have imaging for other reasons, fatty liver, any scan of the abdomen would also see the pancreas, and so we often keep that in mind. If there is specific concerns or symptoms, definitely talk to your primary doctor or seek out a pancreatic specialist.
Okay, thank you so much. Dr. Wiener, a final question for you from our audience here. I am 46 and recently had a colonoscopy. What other tests would you suggest I ask my primary care doctor about? Possibly PSA testing, breast cancer, testicular cancer. No, you kind of mentioned this earlier, so if you want to just dive in here, that would be great.
Yeah, sure. So assuming that there's no family history and you're not African American, then 50 years of age is the proper time to go ahead and do PSA. If you are African American or there's a family history and a first-degree relative who has prostate cancer, then certainly the screening time is 45. I did mention something about dermatologic testing, which I think is crucial. Colonoscopy, if it's normal, should be done every 10 years. So if your colonoscopy was now 46, then current recommendations would be to do it again when you're about 55 or 56. You can easily examine yourself in terms of breast issues and testicular issues. And again, I think the best place to do that is in the shower because the skin is very slippery and you get a good examination that way. But certainly if there's any questions, then you should visit with your primary care physician with respect to that. If you're a smoker, of course, then lung cancer screening And the best thing to do if you are a smoker is not.
Okay, thank you. All right, we'll have one final question and then we'll close it out for the evening. So Dr. Schifrin, this one is for you. Does giving testosterone to aging men increase their risk of cancer and other diseases?
Yeah, so good question. When a man on testosterone therapy, we routinely check PSAs if it's normal, generally once a year. More often if we see a rising PSA. The reason for that is testosterone does not cause prostate cancer. If there's an occult hidden cancer there, it could theoretically make the prostate cancer grow. Other cancers, no, there's no evidence that testosterone therapy causes other types of cancer. And there's also no evidence that it, in long-term studies, leads to increased risk of cardiovascular disease in physiologic replacement. Testosterone abuse is a different story that can cause a lot of other health problems.
I'd like to jump in on that also.
Yep.
And underscore what Dr. Schifrin says. Remember, the idea behind testosterone therapy is to make patients who have testosterone deficiency normal. The idea is to restore them to normal physiologic levels of testosterone. So that if you take a patient, for example, whose testosterone level is low, and then we replete their testosterone to a number between, let's say, 400 and 500 or 400 and 600, we're actually trying to make them quote unquote normal as compared to the regular population. So theoretically, this should not increase anyone's risk of any other disease. It does not cause prostate cancer. It does not cause cardiovascular disease. It does not cause anything else. And because we're actually bringing patients back to normal. And as far as Dr. Schifrin's point, well taken about PSA, is that, yeah, we do know that testosterone does fuel prostate growth, not cancer growth, and it doesn't cause cancer. It will make the PSA go up a little bit in some patients. But then again, there are multiple studies that show that you can give a patient testosterone and the PSA doesn't budge. So Dr. Schifrin's point is well taken, and that should be testosterone is not to be taken surreptitiously. It's not to be taken unless it's under a physician's guidance, and it should be taken with periodic blood test monitoring to ensure that other issues such as blood clots don't develop, because patients who take testosterone on their own are at extremely high risk to develop life-threatening blood clots. So that's the long and the short of testosterone therapy. When given under appropriate physician guidance, it's extraordinarily safe. And in fact, again, throwing literature at everybody, there are multiple studies that show that restoring a patient to normal levels of testosterone actually improves glucose metabolism. It improves cardiovascular metabolism.
Great. I think that's really helpful for people to hear listening. And obviously just a reminder, the importance of doing so under medical guidance. So thank you both. Okay, well, I think it's time to about wrap up this evening. What a wonderful discussion. Thank you so much for some fantastic questions. But I do have one last question for you both. And that is just, what are your goals for everyone listening to tonight's webinar? What do you want our viewers to take away from tonight? Dr. Weiner will go ahead and start.
So I think the overarching goal for me in my practice, as well as for these webinars in general, is to empower patients to take control of their own health. I think it's extremely important for patients to realize that the primary determinant of an individual's longevity, and not only the length of one's life, but the quality of a life, is completely dependent on choices you make every single day. This has to do with adequate sleep, adequate nutrition, minimizing alcohol, avoiding tobacco products, exercising, doing everything you can do in terms of the screening things we talked about to maintain your own health. That's the goal of the men's health program here at Jefferson, where we have this multidisciplinary approach so that men can have a tailored visit and a tailored plan to maximize the benefits that they can receive.
Okay, that's terrific. And Dr. Schifrin, anything that you would like our viewers to take away from tonight?
Yeah, I agree with everything that Dr. Wiener said. Our program does the multidisciplinary approach focuses on many aspects of men's health. So totally agree with being empowered. Don't be afraid to ask questions to your providers. Find a provider that you're comfortable with, someone that is responsive, and take responsibility. If you're someone that has been putting things off, really take a step back, take a look at your health, and you don't need to try to revamp everything overnight. Just take small steps, whether it's focusing on diet or exercise first, and really ask yourself what aspects of your life and mental health as well, really to take control of your health. I agree.
Perfect. Thank you so much. I think this was certainly an inspiring discussion, and good reminders there to take control, and even if it's just one step at a time. So thank you both for your time.
Thank you for the invitation.
Thank you.
Absolutely. Thank you both. All right. Well, and also thank you everyone who is watching for attending and submitting your questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Is there another time that works better? Any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. Be sure to visit jeffersonhealth.org to stay up to date on upcoming classes, events, and webinars just like these. We actually have more webinars coming up in December, and we'll share the upcoming dates and topics in just a moment. Please also visit thehealthnexus.org for more health content, patient stories, research, innovation, and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to planning for pregnancy to robotic surgery. That's youtube.com/Jefferson Hospital. A recording of this event will also be sent to you next week, so you can rewatch, as certainly there was a lot of valuable information shared. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Thank you so much. Have a great night.